Hello, everyone. Thanks for attending today. Sorry I'm a little late. I was just got caught up right at the end of the day, but I'm excited to talk about arthritis here specifically. So I'm sure that could be a hot topic for most people. Everybody kind of deals with it at some point or another in their lives. So my goal is to open up discussion on it and just give you guys the opportunity to ask questions as I go. Feel free. I try to keep checking the chat as I go. So if if you have any questions, you can throw them in the chat or unmute yourself and ask questions. That's fine by me as well. But thanks to Kat for organizing this. So I'm excited that this is the second installment of this presentation of these presentations. And I have some more topics that we can build on as we go. Basically, the whole idea with this is just to answer questions that I oftentimes find myself answering when I'm in the clinic working with patients on a day in and day out basis. And these are things that I think that the general population could benefit from hearing too. So this is why I wanted to do this, to kind of do some community outreach and just get that information out there. I work as a physical therapist at Alliance Physical Therapy. We have a clinic in Murraysville and in Penn Hills, and I'm at the Murraysville clinic full time. So let me share my screen here, and I will get into it. Okay. So I was kind of struggling with the title for this. I'm not sure this is the best title, but we'll go with it. So we're talking about arthritis, specifically here, arthritis of the lower body, because this is 70% of arthritis that's seen in our population is the lower body. So it's very much the most common bit of arthritic conditions, and it's the most limiting. Arthritis in your shoulder may prevent you from reaching up and getting things out of the closet, but arthritis in your hip could prevent you from doing a lot of things throughout your day. So it's really going to throw you off and limit you. Now, some of the observations that I've seen with arthritis is that it is pretty misunderstood. So I want to try to help us gain a bit of an understanding of what it means to have arthritis and what the implications are there. It is uncurable. It's not going to go away, unfortunately. But that you'll see as we go through, that doesn't mean that once you have that diagnosis, it's the end and I better just go get a joint replacement. There's a lot of other things you can do before that joint replacement surgery is really indicated. It is, for the most part, inevitable. I mean, as we age, it's a normal part of aging. So we get it at different points in our lives, depending on our activity levels, obesity, injuries, and things like that. However, it is something that's going to happen at some point as we get older. So we can do, and we want to be able to do what we can to manage it and work with it once we get to that point. So working my way down, my primary goal here with all of these presentations that I'm doing is to promote activity that optimizes function. So function meaning doing what you want to do throughout your day, the way you want to do it, or at least as close as you can get to that. And oftentimes that means some sort of activity. So it makes sense that if we're going to improve the way you're doing activities, we need to do it through activity. So we need to find those activities that will really promote your movement. Now, so movement is really the medicine here as we go through all of this. And that is an important thing to point out initially, because oftentimes osteoarthritis is called a wear and tear disease or wear and tear condition, which is really not accurate. And I have this kind of analogy up here on the screen of if your new tire versus your worn out tire is not the same as your new knee versus your worn out knee. It simply doesn't work like that, because so the implication of calling it a wear and tear disorder is that every step you take is one step closer to your knee wearing out and you having to go get a new knee, which is what a tire is. Every mile you drive, you end up getting 1 mile closer to needing a new tire. Sure, some people use their tires differently and use them a little more aggressively, and they'll wear out faster and slower and things like that. But regardless of who you are and how you're driving, those tires are slowly wearing out the whole time. Whereas with our osteoarthritis, the articular cartilage of our joint, which is the slippery surface between the joints, And you can kind of see that observed here. When you see it on an X-ray, there's nothing where the articular cartilage is. It doesn't show up on X-ray, but there's this nice joint spacing. It's written here. So that joint space is all articular cartilage, and that's super slippery. It's even more slippery than ice. So our joints glide and slide on each other really, really nicely. And as they glide and slide, they're stimulated. There's more fluid flow that comes into the joint, and things change there. But yeah, things can break down and become irritated in the joint. And as that breaks down, though, in that bout of walking or whatever you're doing, it kicks off a healing cascade, then that allows that cartilage to heal again. So the cartilage reheals after injury. So you do something, injure it a little bit, it gets better. Do something, injure it a little bit, it gets better. And actually, as with most things in the body, the more often you put load on that tissue at a reasonable level, the better your body adapts to being able to respond to that load in a positive way and create healthier tissue. So really, activity helps this to a certain extent. So this is a really nice little infographic here about some of the statistics with runners. Now, running is always looked at by the general population as if you keep doing that, you're going to have arthritis in your knees, you're going to have a knee replacement. And I enjoy running, so this might be exposing my bias here a little bit, but this study that this comes from is a randomized control. Oh, I'm sorry, this is a systematic review. So they took a bunch of really good studies and took all the information out of those really well done studies and came up with this information. So it's like a super study in a way. So what that means is this information is relatively reliable. And when we look at the non-runner, somewhat sedentary individual, through the course of their lives, as you get older, your risk for arthritic changes in the hip or knee is about 10.2%. So about 10.2% of us is going to end up with some symptomatic osteoarthritis. And that's the key term there, symptomatic, because otherwise most of us do get osteoarthritis, but it doesn't always have to be painful. Even this picture up here, this person might not have any pain in the joint. They might have some stiffness, but they might have no pain. So you don't always have to have symptoms to have, even if you have arthritis. Now, I kind of wasn't sure because this is pretty bad arthritis here in this joint. This person probably does feel it, to be honest. So 10.2% of non-runners will develop osteoarthritis. If you go over to the left there, recreational runners, 3.5% of recreational runners will develop osteoarthritis. So that is a huge difference. So running at a reasonable amount has a protective effect against arthritic changes in the body. What recreational runners mean is somewhere like 10 to 30 miles a week, somewhere in that range. Whereas if you flip over to the other side, the competitive runner, it ends up actually increasing your risk for osteoarthritic changes at 13.3%. Now, something to observe with this competitive runner, they go into the detail in this study, but these individuals are regularly exceeding 55 miles a week of running distance. So even someone that runs a marathon and trains for it is typically running around like 40 miles a week. This competitive runner are like top tier, high-level competitive runners. And even with those competitive runners, it's partially how much running you're doing, but it's also how long you are keeping up that running. Because remember, when we go up to here, when you're walking and when you're running, you damage that joint, but if you give it time to rebound and recover, then it recovers pretty well. The key is giving it that time. If you're a competitive runner year in and year out, really, really pounding away, you might not be giving your joints adequate recovery time, and you may be creating a constant level of inflammation in the joint that's causing things to break down a little bit faster. So just being competitive doesn't necessarily, just going to a race doesn't necessarily mean you are going to have a significant increased risk of osteoarthritic changes. Really, the key is that you are competing at a very high level for a number of years in sequence. that might increase your risk a little bit more. So I go through that not because you guys necessarily care about running, but I want to show that the most important thing is that to take from this is that there's a bell, like an upside down curve that we look at where not running at all, you have an increase, or no activity at all, you have an increased risk for arthritic changes. Too much activity, you have an increased risk for arthritic changes. And just right amount of activity will significantly decrease your risk. So it's kind of like the Goldilocks runners there in that nice easy zone of getting out and moving but not doing too much. And this doesn't only apply to running, it can apply to walking, it can apply to cycling, it can apply to any activity that really speaks to you. Activity is the key to manage arthritic risk factors, not necessarily the type of activity. So trying to gain an understanding of the misunderstood is kind of this second part that I want to go into. So arthritis, like I said earlier, is a normal part of aging. It happens as we get older, but it happens at different rates with different people, and we've started to notice that it happens earlier in the lives of people living during our time versus historic times. This can be attributed to a couple of different things. The biggest is probably the obesity in our population, and we'll go into detail on that in a little bit. It's not quite as obvious as it seems, but the obesity, and then just the fact that we're living longer too. We're living longer, and we end up increasing the incidence of arthritis. So if you look at the presence of NEOA in individuals older than 50 years, in present-day individuals, it's about 16%. So these studies are all a little bit different, but 16% versus pre-industrial times, it was around 8%, and then prehistoric times is around 6%. So those pre-industrial and prehistoric, they actually went back and looked at skeletal remains of those individuals, and based on the wear that they could see on the tissue, the bones, they could determine whether or not they had arthritis before they passed away. So we could see that things are increasing as far as arthritic changes at the same kind of relative age. So this is something that we need to try to address. I mean, we always we hope that as our technology improves and our understanding of the human body improves, that we're generally becoming healthier. But that's not the case. And in fact, we are living longer, and a lot of, especially those pre-industrial people, are living longer than the pre-industrial individual. But are we actually living for those last few years? And that's the difference between morbidity and mortality. I mean, it's the argument between like actually enjoying your last years versus being laid up and not being able to get around the way you would like, or at least somewhere close to the way you would like. So that's the difference for what we're really seeing in these individuals. It's evidence of that we're not living our lives to fulfillment as we get towards the end of our lives. So this is something that we can have an influence on as we get into the risk factors. We'll talk about those in a little bit. So again, often called a wear and tear disease, and we talked about the running up top there. So the next thing to talk about with this is the obesity is definitely a risk factor for osteoarthritic changes in the lower body. However, it's not a purely mechanical mechanism that causes this. So by that, what I mean is we talk about loads through the joints. So someone that's overweight weighs more and puts more weight through a joint. So the easiest way to think about this is that if you're overweight, your joint's going to get loaded too much and break down faster, which to a certain extent is true and is probably more true in those individuals whose bodies weren't originally designed to carry heavy weights. So by that, what I mean is, people that have a wider frame body, like a bigger frame, their joints are designed to take on that weight of that bigger frame oftentimes. But if you put on way more weight than your frame is ready to handle, then those joints may not be ready to handle those weights because the joints don't change as your weight increases. The joints are pretty much the same. So there is a mechanical component to it. But the other thing that happens in the obese individual is that they generally have increased inflammation. So they have increased inflammation going on in their body that prevents that recovery of the joint tissue. So you break down that joint tissue and then you want it to recover, and that increased low level inflammation that's occurring doesn't allow it to recover to its fullest extent. So then therefore it continues that breakdown process. Another thing that happens in the obese individual is that this is kind of a really interesting thing, and it explains a lot about how it's hard to lose weight once you have it on. But our reward system, like the opiate, internal opiates and things like that, is not as effective when we're obese. So those receptors aren't, there's not as many of those receptors available when we have obesity, when we're overweight. So we don't get that same reward that someone else would if they're in shape for exercising. So that's, I'm sure, as people gain weight, they look around and they say, I don't understand why that person loves exercising so much, and they literally just might not understand because that obese individual doesn't have the same rewards for the same amount of exercise as that fit individual. And you could take this one step further. This is slightly outside of the realm of our discussion, but to talk about food, because food uses that same reward system. So if you're not getting the same rewards for the same food you're eating, then you're probably going to eat more of that food and then become more obese to get those little rewards over time. So this is kind of interesting, and that's why it's tough once you become obese, once you become overweight, to lose that weight. Now, as you do improve the shape that you're in, your ability to be rewarded improves. So that's something nice. So those you do gain more of those receptors as you get in better shape. So obesity isn't just as simple as weight on equating to breakdown in joint tissue. There's those inflammatory cascades and just that general lack of desire to exercise, which we'll see is pretty important. So, and the other thing, as we age, there's a natural increase in general systemic, like full body inflammation that occurs, and there's a lot of complexity to the mechanisms of what causes inflammation and recovery in the body. Getting deep into microbiology, but one of the types of issues there would be the cytokine levels, and those can cause sustained inflammation, amongst many other things, which is outside of our realm of discussion a bit. But just know, with obesity and with aging, the potential for systemic inflammation is increased. With more inflammation, the potential for breakdown of those tissues in the joints is increased as well. This is another factor that's often cited for a reason for arthritic changes in the knee specifically is weakness in the quadricep, which is the front of the thigh muscle, and how it could lead to osteoarthritic changes. Now, this is one. I read a systematic review, so another like super study on this, and it did say that there was weak evidence indicating that this could be the case. Now, weak evidence doesn't mean weak. Basically, what that means is there's some evidence to the positive of quadriceps weakness increasing the arthritic changes, but there's not a lot of great evidence for it. So the way I look at this in physical therapy, though, is if I see a general population of people, whether it's for their back pain or their knee pain or their hips, generally people that I see coming through the door use their quadriceps way more than they use the other muscles of their core and lower body. We've generally become relatively dominant in using our quadricep muscles for our overall daily functional activities, getting up and down out of a chair, going up and down stairs. We don't use the depth of squats that we need to engage your gluteal muscles and your hamstring muscles in the back of the legs. We don't move fast enough oftentimes to use the calf muscles that are more fast propulsive muscles. We don't change directions enough to use the hip muscles more as we go through our lives. So what ends up happening is we use our quadriceps a ton. And there's always a ratio of increased quadricep strength to hamstring, which is the back of the leg strength. That ratio has been also found to lead to issues in the knees. So if there is too much quad strength versus the hamstring, the back of the thigh, then we'll end up with an increased risk for injury and arthritis in the knee also. So it's not just weakness in the quadricep. However, these studies have been done, like most of these studies have been done, so it's always pointed to as a reason for arthritis. I don't think that it's the quadricep weakness that is causing the arthritis. I think that you can use quadricep weakness as a proxy measure for general body weakness, and that's probably what's causing the arthritis. Now, I'm taking a little bit of a jump there, but this is kind of what I've observed through my treatment. So that's the difference in my kind of thought process with this, is that it's really general lower body weakness that leads to arthritic changes in the knees and not specific to the quadricep, because actually we use our quadriceps a lot more than all the other muscles in the body. So what would be interesting is to see a study done that measures all of that and then the risk for arthritis. And with this, it's super important to understand the difference between what a risk factor for a disease and a treatment for a disease. So although something might be a risk factor, it might not be an effective treatment. So with this is always one with the running population. People always identify that they're flat-footed. Flat-footed, I have, so that means that's probably why I have this injury in my foot, where when you actually look at risk factors for running injuries, being flat-footed is not a risk factor to cause an injury running. Now, putting an orthotic in the individual to address their flat foot can help them with their injury, but it's not what caused the injury. It's just taking load off of some irritated tissue for a period of time to then help things recover and heal. So the same thing goes with quadriceps weakness. Just because quadricep weakness is a risk factor for osteoarthritis doesn't mean it's an effective treatment, doesn't mean that strengthening it is an effective treatment for osteoarthritic changes. And in fact, that is a good way to irritate an arthritic knee by really working on strengthening a quadricep, because that joint hasn't been given a great chance to recover oftentimes, and the knee joint is primarily operated by the quadriceps muscle. So if you just keep hammering away at quadricep strengthening, you might irritate that joint a little bit. Now, I'm not saying I don't do that at all in treatment, but it's certainly not the primary mode of treatment. So getting a little bit more into detail on risk factors then. So we have endogenous and exogenous risk factors, meaning basically the endogenous ones we can't do anything about. So our sex, heredity, age, postmenopausal changes, and ethnic origins can increase those are factors that can increase our risk for arthritic changes. The ethnic origins are specific to they've identified that I think European populations have an increased risk for osteoarthritic changes. And then the other ones, though, are things that we can have an influence on. Obesity being one, macro and micro traumas sort of can have an injury or an influence on that. It's something that happens to our body, though. So an injury like a fall or motor vehicle accident. Our lifestyle, so meaning lifestyle basically was noted in the study to be like tobacco and alcohol use. So increased consumption of those products can increase your risk for arthritic changes. And then a resective joint surgery, they don't do these as much anymore in the knees, but they used to actually take the meniscus out of the knee because it was causing trouble. So they just pull it right out. And they've found that those types of surgeries can increase your risks for arthritis. And then there's some argument out there about whether or not even just the regular arthroscopic surgeries increase risk for arthritic changes. Um, but I haven't seen anyone really confidently make that statement with a good study that I've seen, at least. So I kind of have gone through that. I feel like maybe kind of fast, but maybe slow for some because this is boring. But any questions before I move on? All right. So then moving on to the treatment of osteoarthritis. So treating the uncurable. So how do you treat something that's uncurable? Well, it's by understanding that it is inevitable and you're not actually treating the condition to resolve the condition. You're treating the person to help continue their activity in spite of the condition, because that is really what our bodies have been designed to do. We can continue to operate even with these arthritic changes, and we can operate reasonably well. I mean, we're not going to be doing the same things we did when we were 20, when we're 70, but we can do a lot more. Our bodies are capable of a lot more than we let off oftentimes. And one of the most important aspects, and that's an important thing to understand because I'm going to skip down here. One of the most important things to consider with this treatment is that we have to believe in ourselves. I mean, it's kind of funny to say it, but we really have to believe that we can get better. If someone doesn't believe they can improve, then their ability to improve is going to be kind of non-existent. So they've got to believe that they can improve. So through our treatments, we have to, as physical therapists, we have to help people understand that there is a path here. But we also have to be realistic when that path seems to either not be there, that's very, very frequent times, or if it is there, that there's going to be a ceiling effect. Like I can get you moving a bit better and tolerating XYZ activities, but ABC activities, you're just not going to be able to do those anymore because the tissues aren't really going to tolerate that well. So we have to be realistic and make sure that we can help that person live up to those lifestyle expectations that they have. So in making sure somebody, and confidence with respect especially to physical activity. So the patient's ability to confidently perform physical activity. So those that have done it in the past and done it throughout their lives are always in a better place here at that point when they have arthritic changes to dive in and be confident with those activities. Those that haven't, it's always a little bit more of a struggle to build them up. But that's not to say it's not possible in those individuals. So that's where in physical therapy, I remember when I was applying to physical therapy schools and I was looking at the prerequisites and it had like psychology prerequisites and I thought, what's the point of this? I just want to help people exercise and help them feel better and get them moving. Now I realize that psychology is a huge part of physical therapy and just understanding individuals' motives and trying to help them understand why we're asking them to do something that sometimes might not feel great, with that idea of making long-term gains. Let's move back up to the top here. So number one, so we're looking to improve the health of the articular cartilage. Now, something that's really important to know about articular cartilage is that movement is nutrition because the articular cartilage has a very poor blood supply. So oftentimes blood comes from, or nutrients come from our blood. I believe we talked about this last time if you were part of the discussion last time about the low back pain and disc health. Discs are the same way. Discs don't get much blood flow and neither does your articular cartilage. But a lot of the other parts of your body, your bones, your muscles, your skin, and everything else gets nutrients through blood flow to that area. There's a good blood supply. Articular cartilage and discs, intervertebral discs, get that nutrition from motion, like body motion. So as we move, new tissues move in and old tissues move out, back and forth, and it creates kind of a flow of nutrients in and out of the joint space or the disc space. So if we're not moving, there's not a good turnover of nutrients in the system, that can lead to those nutrients all being used up. So just like anything, if you use up all the nutrients and there's nothing left, like if you have a plant and you keep watering it, but there's no nutrients in the soil, that plant's going to die. So it's the same idea here. We've got to give it nutrients. We've got to give it nutrition to heal. So that's a big part of physical therapy, getting things moving. Then within that of improving the existing cartilage health, there are some injectable therapies that have been found that have been identified to be helpful. There's a lot of debate about these in the medical world about how effective they truly are, but I always think it's worth the discussion because the evidence that I've seen coming out recently seems to have some positive indications for like mild osteoarthritic changes and having a positive effect on mobility in some of these joints, especially with PRP injections. So PRP is short for platelet-rich plasma, and basically what they do is they take your blood, spin it down to its most nutrient-rich product, which is the platelets, and then inject it back into that joint. And what this does is it optimizes that healing environment. So like if we scroll up and you know how I was talking about with those runners that are running all the time, not giving things a chance to heal, and then therefore it's always in this inflamed state. When you inject that PRP, it optimizes the healing environment and gives it to heal, to take it out of that inflamed state, to kind of slow that process down. Stem cell injections are really the same deal. They're optimizing the healing environment. I think, from my understanding, not being a medical doctor, but my understanding of the research is that the ability of stem cells, the original thought was we would inject stem cells into an area and they would basically become whatever tissue, whatever cell you needed. So if you needed more cartilage cells, they would become cartilage cells. If you needed more bone cells, they'd become bone cells. They're finding that that's not really the case. Even when it does help, it's helping because it's optimizing the environment for healing. So these injectable therapies could be options for improving the cartilage health. Another consideration for addressing the arthritis is to decrease the inflammation and/or pain. So there are some dietary changes that can be made to decrease inflammation. That's outside of my realm, but there's considerations to be had there. And if you are interested in looking at that, I would look into talking to a dietitian about that. As a side note, there's a difference between dietitians and nutritionists. Dietitians actually have a 4-year degree in dietetics versus and they can bill insurance for their treatments, versus nutritionists are kind of anyone who thinks they have a knack for nutrition. So dietitians are really out there to treat medical conditions, whereas nutritionists can kind of help people with diets and things like that. So in this case, I would look more towards like an outpatient dietitian. Medications can certainly help improve inflammation. However, those come with some side effects. Injectable therapies for inflammation would be corticosteroids, but those also come with side effects. They can be very effective at decreasing pain, but they can also increase the breakdown of the joint surfaces. Now, that is after a number of injections, most likely after a number of injections. And so that's something that you don't. Each individual is going to have to take that on their own case-by-case basis as to whether or not they consider an injectable therapy like a PRP or stem cell or a corticosteroid therapy. Now, one thing I would say is that these up here, the prolotherapy, stem cell, and PRP, are typically not covered by insurance, whereas the corticosteroids are. So that draws people a little closer to trying these first. It'd be nice, and someday, hopefully, the other options really are covered by insurance. But there's just not enough strong evidence out there to support their use for insurance coverage, at least. So electrical stimulation can also help calm down pain. So using like a TENS unit around the knee on those days where it's extra achy can help calm things down. the idea there is basically fooling the nervous system into decreasing those pain signals that are coming back and forth from the area of the pain and helping you do a little bit more. So that has been found to help with arthritic pain. And so another concept when we're managing osteoarthritis is we need to change the load on the joint. So do what we can to decrease that load. I talked about this earlier, where we can decrease the load through a joint by increasing the load on other joints. What that means is we decrease how much we're using the quadricep and increase how much we're using the hamstrings and calf muscles and core muscles. So if we can take that load that's all going through the knee joint and take a little bit of it and put it into the ankle joint, a little bit more of it and put it into the hip joint and maybe even into the spine a little, we can take down that load through the knee and help you do more effectively throughout your day. So strengthening other joints goes a long, long way in treating osteoarthritic changes, and this is probably where my treatment comes from most oftentimes, just trying to help people distribute that load through the rest of their body, improve their movement awareness, and improve their ability to use other joints and other muscles. That can be a really effective way. In our pool, we have a pool in our Murray's office, so we have the ability to decrease loads through those joints just by putting you in a minimally weight-bearing environment as well. So that can be a huge bonus for people, being able to get in that pool and start moving initially, get that process going, and then as they gain confidence and gain a little bit more strength in that inflammatory cascade is maybe slowed down a little bit, you can get out and get moving on land and then really optimize their ability to move around, to each individual's ability levels. Bracing can also help decrease load on those joints, so that's a consideration. I've seen some studies done about knee braces for arthritic knees, and there's always a concern when we brace something, are we making it weaker by bracing it? And those studies found that they basically took two groups of people, and they all had knee arthritis. In one group, they gave a brace for a year, and the other group, they did not brace for a year. And they assessed their quadricep strength, the front of the leg muscle, at the beginning of that year and the end of the year. And both groups had the same strength in the quadricep. In fact, it wasn't significant, but in fact, there was a trend that was occurring in the braced group, with the people that wore braces, that their quadriceps were a little bit stronger than those in the non-braced group, which I found was interesting. And realistically, from what I've seen in the clinic, that makes a lot of sense, because oftentimes when people have knee arthritis and it's pretty painful, they avoid using their quadricep whenever they can. They'll go downstairs and just not use that quadricep or minimally use it. So if the brace was able to help them decrease pain a little bit, then they were probably more likely to use that quadricep during functional activities through the day. So that's a really a viable option for people that have some arthritic changes. Low impact activities. So I just wrote there, note the term impact. So it's not necessarily about amount of load as it is about the impact of the load. That's what really causes inflammation, those heavy, fast loads. So we can do heavy loads that aren't extremely fast and wouldn't cause quite as much inflammation. So running, that's probably not a great thing to do with some progressed osteoarthritic changes. However, there are plenty of people out there that do it. But walking, cycling, swimming, those things really are nice for those arthritic joints. They can really help improve the nutrition in the joint by getting fluid flow in and out of the joint without causing too much impact through it. We already talked here about number 4, and then moving on to the next option for management of osteoarthritic conditions is the surgical procedures. So there are basically 3 different procedures that are out there. So you have the arthroscopic surgeries, where this is the one that the orthopedic surgeon will say, I'm just going to go in and clean out the joint. I'm just going to clean out the arthritis. So they'll go in and perform that procedure relatively quickly, and oftentimes people are up and running relatively quickly afterwards. The evidence on how effective these are is starting to become a little bit questionable. However, I think, like with anything, there are individuals that can absolutely benefit from it. I think it's just a matter of better patient selection as being a key in this case. So picking the patients that really seem to have the indications that would benefit from this the most, instead of just trying to go in and clean out everybody's joint. The next level of surgery, it can be a resurfacing. From my understanding, I don't think I've not really ever seen this done in the knee. This is more often done in the hip joint, and it's best for individuals under the age of 60 typically. Where if you think about our hip joint, we have a ball and a socket joint. And in the resurfacing procedure, they just basically put a little piece of metal in the socket and then a little like hat cap on the ball, and they just kind of resurface it. And the recovery is relatively quick, and you don't have all the precautions that you would with a total hip replacement and things like that. So the benefit is that it's a fast recovery, and you're preserving that for potentially a full hip replacement later on down the road. So those people that have like premature arthritic changes in their hip for whatever reason may benefit from a resurfacing procedure. Say they're 45 and they need a new hip, so you get a resurfacing procedure that gives you a few years before needing the arthroplasty, and then you could hopefully have enough time that arthroplasty would live, would last well throughout the remainder of your life there. So resurfacing is an option, whereas the arthroplasty in the hip, they actually get rid of the whole neck of the femur and everything. So they basically, it's kind of, I was reading somewhere, I don't know, this was a while ago, but the resurfacing procedure is like putting a hat on, and the arthroplasty is like cutting your head off. So you're taking like the whole head of the femur off in the arthroplasty and putting a new one on. And then the total knee replacement procedure is honestly a little bit more, and this is where I'm not sure the difference is in nomenclature, but that total knee replacement is a little bit kind of similar to a resurfacing procedure where it's kind of just a new surface. However, they do hammer it down into the bone as well. So those are the surgical options. Biggest thing I would say about the arthroplasties, like the total joint replacements, is the best thing you can do is wait until that the best indicator for a joint replacement is pain. So weakness, stiffness, all those things don't play as much of a role as pain. Like if you get up every day and you're in pain, and you've tried conservative care, you've tried some injections, you've tried physical therapy, you've tried getting in the pool, you've tried changing your diet, you've tried some stim and medication and all those things higher up on our list, then you're at that point where you would want to consider a total joint replacement. But until you're there, you really don't want to do this prematurely, because the reality is that the replacement parts are just never as good as the original parts, because the replacement parts operate much more like these tires than our joints. So those replacement parts, they just wear out over time. So that's something that you really need to consider. Those replacement parts do not heal. They just slowly wear out. Now, with technology the way it is advancing, the replacement parts, the longevity of those has been improving significantly. So it's not a surprise. It used to be like 10 years. Now it's not a surprise to get 15, 20 years out of these total joint replacements, and maybe even more. I don't keep up on that very well. Okay, that was what I had to talk about. So again, I'm with Alliance Physical Therapy. We have a clinic in Murraysville and in Penn Hills. We have a pool in Murraysville, which is great for arthritic conditions. And you don't actually need a referral to come see us. We all of our direct access license, so that means you can walk in right off the road, and we can evaluate you and start your treatment, and then we'll correspond with your physician accordingly to let them know that you've come over and we're helping you move a little bit better. All right, that's all I had. What questions do you guys have for me?
Yeah, I have a question. The
Yes.
question was about light therapy. You talked about electrical stimulation. Do you know anything about light therapy or light stimulation?
Yes. So often it's called like laser therapy or laser light therapy. Is that what you're talking about?
Yes, yes.
Okay. So that is we do have at our clinic actually we have cold laser that we'll use here and there. The evidence for it is very spotty. And for arthritis, I haven't seen anything that's really good yet. The best evidence that I've seen for that is in support of some tendon conditions like tendonitis that really is chronic, or maybe some plantar fasciitis conditions that are very chronic that we can effectively treat with laser therapy. Otherwise, it's I'm not going to say it won't help because laser therapy basically the idea is promoting nutrient flow and blood flow, so it goes along with kind of what we're talking about. I think the argument there is, does it really get deep enough to the joint surfaces to make a difference?
My experience with my mother was she had severe arthritis. I took her for several treatments, about 4 or 5. She seemed to move a lot better, but I didn't know, like she could open and close the door of the car better, various things, but I didn't know if, if it was a, um, just my feeling, or there was no, I couldn't actually measure other than seeing her moving better. So you thought it was more tendon. The tendons were bad. It was helping her.
Well, that's if they have like a tendon issue, a known tendon issue. It can be helpful there. Um, it's hard to say in her case what it was, what helped. Um, but we get to a point, especially when we're dealing with people that have chronic issues, that yeah, whatever helps. That's great. Like I don't, I'm willing to try a lot of things, and that's especially in our practice. We have the pool, we have laser, we have a lot of options. We have needling options. We have a lot of options because we believe in not giving up and trying to find our way through and help that patient to optimize their abilities. So it's something that we will certainly kind of work through and go down that cascade. So usually what we'll do is start with the things that are most evidence-based and then work our way down. And if we get all the way to the bottom and we haven't found something to help you, then we may not be the ones to help you. But we'll work our way down as best as we can. And so, yeah, I mean, that's great to hear that the laser could potentially help more with the arthritic conditions. And I've tried it here and there, and there's times where it seems like it has helped. But the challenge is always that we're throwing a lot at it too. So it might have been the exercise, it might be the laser, and it's really hard to definitively say one over the other sometimes.
Thank you.
Question now.
Yes.
I had a whole body scan a couple months ago, and one of the results they found was and I just don't understand what it's trying to tell me here, that the roughly systematic areas of the increased radiotracer activity at the sternoclavicular joints, shoulders, knees, and ankles are consistent with chronic multifocal osteoarthritis. I'm not sure
Okay.
about the pronunciation on some of that, but I
I think you
guess
got
I just don't quite understand what they're telling me. Is
right.
it something that's going to happen, or it is happening, or how bad is it going to get?
Yeah, so there's a lot of factors there that to consider as far as how bad is it going to get, like what your age is, what your activity level is, and things like that, and the specific joints that they were able to identify that in. Um, it's it, but it, you know, like I said, it's a normal part of aging, so I wouldn't necessarily let it set off too many alarm bells in your case. But it's something to be aware of, and it's something, like actually, I put my email on the chat there. If you want to send it to me, I'd be happy to look it over in a little more detail. But like I said, it's hard to really say definitively in your case without knowing you what that really means. However, it's something that you might not want to just let go. You may want to try to address it in one way or the other.
Okay, monofocal osteoarthritis, what does that mean?
It means it's in like multiple places. Like I'm not really sure what the scan was that you got, but that there's multiple points of arthritic change.
It was a bone scan.
Bone scan. Yeah, okay, so this is kind of so it was throughout the body that they didn't define any specific joints. They just said there's arthritic changes in a few different joints in the body is how I would interpret that.
Okay, thank you.
Sure.
I have a question. Um, I am trying to avoid taking medications, and from what you're saying, maybe that was the wrong thing to do. I just kind of have a level of pain that doesn't bother me that much, and I try to avoid it because of the gastric reflux, the non-steroidals and things like that. And so am I wise to avoid that, save it for later when it gets worse, or should I be taking it more preventatively?
So that's a good question, and I could see where you're coming from with the discussion there. I would say that it's all about balancing the risk and reward involved in taking that stuff, and the heavier and non-steroidal anti-inflammatories. I mean, like ibuprofen, naproxen, and those things aren't really great to take regularly long term because they do have some gastric side effects that I think the other thing I always think about is like Advil has like a candy coating to it. It's like it's a candy, but it's really not. It's a pretty serious drug that we need to respect a little bit more, I think. So I don't disagree with you in not taking it, but and medication is just one part of the way that you could decrease the inflammation. So there's a lot of other ways you can approach the chronic inflammation that you might be dealing with through diet, through activity, through just getting better sleep. That's even another thing that we didn't talk about. But there are other things that you could try to improve to prevent the inflammation before starting to take the drugs that are a little bit more aggressive. And I mean, everybody loves to talk these days about turmeric and all of those other things as far as other like natural or holistic medicine. But the thing is with that stuff is that they have side effects too. I mean, just because it's natural doesn't mean it's side effect free. But it is a little less aggressive and it's a little more watered down. So it's something that the side effects oftentimes aren't as bad with. So that could be something you could consider. And that's a discussion definitely like on that diet side for a dietitian.
Okay, thank you.
Mm-hmm. So,
Hi. Sorry, I just wanted to say hello. I'm Marla Mothersbaugh. I think you work with my daughter.
yes,
And I was
hi.
a hospital case manager for 25 years and worked in the orthopedic unit. So I appreciated your presentation. I thought it was very good. Of course, I knew a lot of the stuff from all the work I did with it, but it was very good. I thought it was very informative.
Great, thanks. Well, hi. We love your
Hi.
daughter. She's great. I've known her for a while, so it's so exciting to have her on board.
Good.
I have my email up there. If anybody has any pressing questions or other questions they want to ask, feel free to shoot me an email and I'll be happy to get back to you. But otherwise, thanks for listening in and I appreciate it. And I think the next discussion will be on osteoporosis. So that should be next month. I forget the date. I don't know if Kat, if you have the date or not, but Thanks
We
for
could talk about it.
tuning in.
Thank you for joining us.